The IPRO End-Stage Renal Disease Network Program has developed the following training: COVID-19 pandemic, screening, triage, and patient management for the dialysis provider to fulfill the educational requirements the Centers for Medicare and Medicaid Services contract. This training will supplement the Centers for Disease Control and Prevention educational materials. We are aware that you are vigorously implementing and adhering to best practices and your facility policies. The objectives for this presentation are as follows: support the philosophy of a call-ahead culture, describe how to identify, isolate, and/or cohort, and report confirmed COVID-positive patients or patients under investigation, educate and enforce visitor restrictions to reduce the spread, describe how to appropriately discontinue isolation and/or cohorting, share best practices learned from the network community, and describe how to maintain situational awareness at the local and national level. All staff and patients should have education on whom to call if they suspect symptoms prior to arrival at the unit. This creates the call-ahead culture. Staff should receive training on how to triage phone calls and to best determine the proper care setting for the caller. Healthcare personnel should be educated about the policies that are in place in regards to reporting to work related to the pandemic. Staff need to be supported in making good decisions, avoiding the workplace if they have any concerns related to possible exposure or if experiencing COVID-19 symptoms. The development of a call-ahead culture between care partners promotes a transparent, bidirectional communication at each transition of care. These calls assure all healthcare personnel are aware of the patient's COVID situation. Calling ahead prior to any care transition is necessary if the following situations exist: signs and symptoms of the illness, exposure either in the home, nursing facility, or community, high rate of infection at the place of residence, and pending COVID testing. The next session is on rapid identification, isolation, and reporting of patients with confirmed or suspected COVID-19 infection. Step 1 is how to proceed when a patient is identified with symptoms of COVID-19. First and foremost, mask the patient immediately. Next, isolate him or her in a separate room or at a minimum assure 6-foot distance from other patients. Once these safety measures are taken, call the patient's physician for instruction related to sending him or her to the hospital and acquiring testing. Determine the patient's stability with the physician and discuss the disposition of where to dialyze the patient, either in-center, a cohort facility, or hospital. If dialysis is being rescheduled, to send the patient to a cohort facility with the approval of the physician and discuss the patient with the patient and caregiver to assure they have a thorough understanding. If it is determined that the patient needs to be sent to the hospital, call the emergency room to notify the emergency room staff of patient's arrival and suspected COVID status. Arrange transportation and notify the transportation of patient under investigation status, or PUI. Step 2 is to isolate patients with COVID-19 or PUIs who will remain in your dialysis facility. All of the COVID-positive patients or those under investigation will need to wear a mask at all times and be kept 6 feet from all other patients during their treatment. The best possible practice when dialyzing these individuals is to utilize an isolation station in your facility if it is so equipped. You must follow serologic testing guidelines for use after hepatitis B patients. It is also recommended that the positive patients or persons under investigations be dialyzed on a later shift so terminal cleaning can occur. Many clinics without the option of an isolation station have opened a shift at the end of the day to dialyze positive patients and another shift to dialyze PUIs. The best option, if available, is to transfer care of the COVID positive or PUI cohort facility that your organization has identified in the region. Remember, this is a scary diagnosis and time for patients and families, so please communicate thoroughly all steps that you are taking to keep everyone safe and appreciate that they will be anxious and need additional support to understand changing shifts or sites for dialysis. Make every effort to assure they do not miss a treatment. Step 3 is to report cases of COVID-19 for your internal facility guidelines. This reporting should assure the local and state health departments are aware of all positive cases. If you are an independent facility, you will need to complete the Kidney Care Emergency Response, or CASER, Emergency Situational Status Report provided by your network. Large dialysis organizations are compiling this data daily and reporting directly to the CASER team. All healthcare partners that are involved in the care of patients should be notified of the patient's status. For example, the patient's residence or transport service, thus promoting the call-ahead culture.
This section describes visitor management to reduce spread of COVID-19. Visitor access during the pandemic should be restricted. Allowances should be made to permit visitors for the purpose of communicating triage information and translation for the patient. Visible signage should be posted at each entrance to communicate and improve understanding of the change in visitation policy. Patients and staff should be directed to utilize a single entry where screening occurs. The next section of the presentation addresses the CDC guidelines for the discontinuation of transmission-based precautions for persons under investigation or persons with a confirmed COVID positive diagnosis. The two terms we have heard in relation to the COVID pandemic is related to sequestering like groups. Quarantine. This situation is used to keep someone who might have been exposed to COVID-19 from others. A person with likely exposure should self-quarantine and limit movement from the home environment. These patients should be separated from patients not known to be exposed by a separate shift or day of the week. Rescheduling of these patients should be considered to keep this group from the general population. Furthermore, this group could be further cohorted as persons under investigation with symptoms or those without. Facility and organizational policies should be followed. The decision on how to cohort will be determined by facility capacity and staffing requirements. Isolation is the term used to separate those patients known to have a COVID positive diagnosis from the well patient population. These patients will be followed by local and/or state health departments to manage their isolation in their home. These patients should further remove themselves from other persons in the home by providing a specific sick bedroom or space and utilize separate bathroom facilities if possible. Dialysis patients who are in isolation still need to receive treatment. This requires isolation efforts at the facility as well as during transport. The CDC discontinuation of transmission-based precautions for patients with COVID-19 have recently been updated. Criteria are now defined by whether the person was symptomatic or without symptoms. These criteria further differentiated into two strategies. Symptomatic patients with COVID-19 may be released from transmission-based precautions using either a test-based strategy, which dictates that the person has two negative test results taken 24 hours apart. Along with negative results, the patient must demonstrate improved respiratory symptoms and the absence of fever without the use of fever reducing medication for 72 hours. A symptom based strategy uses a timeline from the identification of initial symptoms to their resolution. The timeline is 10 days from the first appearance of symptoms. Additionally, patients must demonstrate 72 hours of improved respiratory symptoms and the absence of fever without the use of analgesics. Those patients with laboratory confirmed COVID-19 without symptoms may be released from isolation following the test-based or symptom-based strategies. Test-based strategies requires two negative tests taken after 10 days have expired from the first positive test. Time-based strategy is a 10-day timeline from initial positive test, assuming they did not develop symptoms during this period. This timeline may be altered by local and state health departments or your organization's protocols. Discontinuation of quarantine for persons under investigation or PUIs are as follows. This must include one negative test. Discontinuation of isolation is not dependent in any situation on hospital discharge if the patient can be managed safely in their residence. Communication with nursing and long-term care facilities should occur to best determine the timeline associated with these events and to assure that these facilities are following CDC guidelines for the discontinuation of isolation. One of the network's roles is to collect and share best practices. We have supplied a list of interventions and practices that have shown to be effective during the pandemic. Maintaining a social distance of at least 6 feet in the dialysis facility has been accomplished in many ways. Establishing one-way traffic patterns in frequently traveled hallways, staff breaking and lunching in their cars or in separate offices, removing chairs in the waiting rooms, and having separate waiting areas for sick or suspected patients. Patients should remain in cars or transport vehicles until treatment can be initiated. Transmission-based precautions must be followed to prevent the spread of disease. Early in the pandemic, it was identified having all personnel and patients wearing masks was established as a best practice. Frequent and regular disinfection of commonly touched surfaces is key to prevent the spread of the coronavirus by contact. Special attention should be focused on plastic and stainless steel surfaces. These include phones, televisions, blood pressure cuffs, thermometers, keyboards, carts, scales, sinks, and door handles. Single-use supplies and materials should be discarded. Bleach at the dilution of 1/3 cup to 1 gallon is an acceptable cleaning agent and carries a bloodborne pathogen rating. The cohorting of like COVID status patients on separate shifts or at separate locations has shown to be a best practice as it enables caregivers to best monitor symptoms, timelines, and dates for testing. Staffing patterns at these isolation facilities will reduce staff exposure and risk. The allocation of appropriate PPE for the care of these patients with suspected or positive COVID-19 status to these facilities allows for the practice of inventory management. Facilities not within a reasonable distance from an isolation facility have opened on alternate days or have additional shifts to accommodate these patients. Time must be allowed for all general population patients to exit the building prior to allowing these groups to enter. Terminal cleaning with an improved disinfectant must be completed following these isolation and cohort sessions.
To best educate and enforce protocols and guidelines, your facility should have an understanding of situational awareness on both the national and local levels. The Centers for Disease Control and Prevention has dedicated a web page to provide guidance to outpatient dialysis facilities during this pandemic. This web page also contains resources and related guidance for your use. CDC has created a coronavirus 2019 or COVID-19 outpatient dialysis facility preparedness assessment tool. This checklist allows you to measure your processes in place to monitor your facility's readiness. Reviewing this with your medical director and QAPI team would assist facility leadership to assure CDC guidelines are being utilized to direct patient care, maximize PPE utilization, and environmental cleaning. A benefit of this tool is to prompt thoughtful discussions related to improvement on pandemic response as needed. A completed checklist should be kept in your emergency preparedness manual. The IPRO End-Stage Renal Disease Network program consists of 4 networks, and each network has its own website. Each network has initiated a COVID resource website for both professionals and patients, including resources, and this will be routinely updated. Please refer to your specific network website to find the most current information and resources. The network program is supporting a 24-hour, 7-day-a-week COVID-19 hotline for the purpose of providing assistance to providers and patients who are undergoing an emergent problem related to the pandemic. Please see your network's main page for the hotline number. At the onset of the pandemic, the IPRO End-Stage Renal Disease Network program initiated a branded emergency messaging communication to keep the community up to date on CMS and CDC guidelines and protocol, as well as resources developed to support the end-stage renal disease population and related state and national press releases. These emergency communications provide notification of upcoming webinars related to the COVID positive patient care and management. A section of each emergency message also includes resources specific to patient-centered need and education. We will continue to garner and spread best practices to support the end-stage renal disease community. National resources for COVID-19 pandemic include those from the CDC and CMS. The Kidney Community Emergency Response, or CASER, is actively monitoring and assisting during this emergency situation within the end-stage renal disease community. IPRO end-stage renal disease programs hold 4 CMS contracts. Network 1 represents the New England states. Network 2 represents New York. Network 6 represents Georgia, North and South Carolina, and Network 9 represents Kentucky, Indiana, and Ohio. Each state within each network operates a website where updated COVID-19 information can be found. All resources for this presentation can be found in the accompanying toolkit. This slide presentation and recording can be found on your network's website. The network would like to thank each facility for their dedication, compassion, and hard work during this challenging time. This is the conclusion of this presentation. The goal of this presentation is to assure that you have education and knowledge to meet the 6 objectives of this program. When you close this webinar, please complete the mandatory attestation to verify that your facility is able to list appropriate screening and triage measures to minimize exposure, describe how to identify, isolate, and/or cohort and report confirmed COVID-positive patients and persons under investigation. Discuss the appropriate transmission-based precautions to take to prevent the spread of the virus. Describe how to appropriately discontinue isolation and/or cohorting. Describe how to maintain situational awareness at the local and national level. Report use of telehealth by home programs, either standalone or those associated with an in-center facility. If there is an objective you cannot attest to within the survey, please reach out to your network contact as indicated in the survey for additional education and support. We ask that you return this survey to your network by June 20th to allow the network to compile and report the results to CMS.